complications, the urologists really appreciate thoracic epidurals, working thoracic epidurals. At least try it. We had the case that a couple of weeks ago that a patient really suffered from not getting one, and it was I visited him in the ward, and it was a bunch of mess. It took them 2 more days to discharge him from the hospital. So we are putting a real solid base and fundament with this good management of the epidurals. So if there are contraindications, please do that. And these little organs, these little complicated organs, receive 20% of the cardiac output, which is amazing, and it is an impressive number. I was reading today that the kidneys get an 8-fold or 10-fold on blood supply while at rest, more than a maximally contracting muscle. Think about it. So, about the anatomy, you see the renal artery, and you see the renal veins. The renal arteries branch off, and they give the segmental arteries. When from the segmental arteries, they have anastomosis into the interlobal arteries, and the same for the veins, with going back to the renal vein. And this is a heavy supply of this organ. That's why when we're doing the urology, the partial nephrectomies, the risk of bleeding is so high. They're continuously cutting in super well perfused areas, so it is unavoidable to have less than 400, 300 cc's of blood loss. As you can see, this is very complicated structure with the cortex, the medulla, and the collecting vessels leading to the ureter. We're going to talk about the afferent arteriole. We're going to talk about the efferent arteriole and about the juxtaglomerular apparatus. And you can see the different supply with the vessels, especially with the vasa recta, which is contributing to the counter current in the deepest of the medulla, increasing the tonicity in about 600 milliosmol. We have 1 million of nephrons in every kidney, composed of capillaries, which are forming the glomerulus. And you have a long system of tubules for filtration and reabsorption. The glomerulus is only in the cortex, in the outer side of the kidney, embedded in the Bowman's capsule, and it has a unique anatomy in terms of having 2 arterioles supplying the afferent arteriole and then the efferent arteriole. The pressure, the hydrostatic pressure, which is applied on the glomerulus, can be altered by both altering the pressure of these 2 vessels, and there are different hormones and drugs which are having an effect on both of these vessels. And then you have the renal tubule. You have the proximal convoluted, the loop of Henle, and the distal convolute ending in the collecting duct, and the collecting ducts are ending into the ureter. So the first function of the kidney is the filtration. It is the very first step in the urine formation, and it is more or less and basically bulk transport of fluids through the glomeruli, and the result of the hydraulic pressure brings out glomerular filtration rate, which is pretty impressive, around 180 liters per day. Then the reabsorption, it is the process of returning the filtered mass of electrolytes and fluids back into the bloodstream. More or less 99% of the amount filtered. Then may involve some transport protein and passive and or active transport. Very important here too, glucose is 100% or should be 100% reabsorbed. And then you have the secretion, substances, electrolytes, water, filtered by the nephrons, are secreted, and you also have an active transport of toxins and antibiotics like saccharin and penicillins. And the excretion is the net loss of fluid in form of urine. That's what we see in the bottle, which is more or less the amount of filter plus the amount of secreted minus the amount which is reabsorbed. The glomerular capillaries, it is a very complicated structure. You remember the podocytes and the membrane and the tight junctions and how the ions with the negative load were kept back and the ions with a positive load were I understand. Good. So the endothelial cells have large windows, about 70 to 100 nanometers, and the epithelial cells have only 25. And both of them are providing an effective barrier for cells and large weight substances. This is the most important thing that we should remember, we can remember from the nephron. The GFR, again, it is 125 milliliters per minute, makes 180 liters per day. And there are some factors influencing the glomerular filtration rate, which is the increased renal blood flow means increased filtration rate. The decreased plasma protein that we see in patients with liver and or kidney disease, that they have the edema, is mainly because the decreased plasma protein and the pressures. And then, of course, the hemorrhage, the decreased capillary filling pressure. Very important in this structure, in the mesangial cells, between the basement membrane and the epithelial cells, they are reacting to various hormones. When they are having contraction because of the angiotensin II, vasopressin, etc., they are reducing the filtration. If they are getting relaxed by the ANP and the prostaglandins, we have an increased filtration. And this is the typical USMLE question about the afferent vascular and the efferent vascular. So the filtration pressure is direct proportional to the efferent arterial tone, and it is inversely proportional to the afferent tone. The proximal tubule, 65 to 75 of the ultrafiltrate is isotonically reabsorbed. The sodium, it is the main place where you can find the sodium reabsorption, which is an active transport by sodium potassium adenosine triphosphatase. Angiotensin II and norepinephrine increase, dopamine and phenoldiazepam decrease the proximal reabsorption. And it is the main place where the reabsorption of bicarb takes place. And there is one little protein, aquaporin 1, which is regulating the passive water movement. There's another one, aquaporin 2. We're going to see that a little bit later. The loop of Fenwick, we have descending and ascending. The descending goes deep into the medulla and then turns back as the ascending, and you have two parts of the ascending. You have the thin and the thick part of the ascending part of the Henle loop, and it maintains a hypertonic medullary interstitium mainly through the counterpart vessels that they are crossing at the very bottom of the medulla. Only 30% of it's getting less and less, only 30% of the ultrafiltrate is reaching the loop. There you have another 20% of reabsorption of sodium. And the solid and water reabsorption in that place is mainly passive. There is an exception. The ascending thick segment, sodium and chloride are reabsorbed in excess of water. So again, as we go from the medulla to the cortex, the solution, the filtrate, is getting hypotonic again. And the thick, because the thick parts are impermeable to water and the surrounding is hypertonic. Very important, calcium and magnesium reabsorption site. So more or less this, in that slide you can see where all these changes and the reabsorption are taking place. Any idea of how the pressure in millismol is down here? Yeah, exactly. Between 800 and 1200. It's pretty amazing pressures. Now we have the distal tubule. Only minor modifications. Still, as part of the thick ascending part, still impermeable to water and sodium. This is the major site of parathyroid hormone and vitamin D mediated calcium reabsorption. In the collecting tubule, you have the principal cells and you have the intercalated cells. The intercalated cells are responsible for the acid and base regulation. The medullary collecting tubule goes down from the cortex to the medulla. It is the principal action site of ADH. ADH is modifying the expression of aquaporin 2. Dehydration increases the ADH secretion, and the luminal water permeability is increasing. Very specialized apparatus between the afferent arteriole is the juxtaglomerular apparatus. It is a very special segment which the cells contain renin. The release of renin is happening after beta-1 adrenergic sympathetic activation, and the changes in afferent arterial pressure are in chloride flow past the macula densa. Something very important about the kidneys. These are the only organs which the O2 consumption is determined by blood flow. In all the other organs, it is the reverse is true. So the blood flow is determining the O2 consumption. So we have 80% of the blood flow is in the cortex and 15% to the juxtamedullary nephrons. The PO2 in the cortex is 50, and the deeper you get, the lower it gets, which makes the medulla extremely vulnerable to hypoxia and ischemia. And the GFR is about 20% of the renal blood flow. How does the kidney control the blood flow? Mainly the autoregulation, maps between 80 and 180 millimeters. Blood flow is decreased in less than 70 millimeters. Try to have the pressures, the maps about 70 when you have no contraindications, because I've seen several cases where the surgeons were complaining of oliguria or missing urine, and the maps were throughout in the 60s or in the 50s. Now with the EPIC, we may get some troubles if someone's going to open the chart and see that it's very easy to get back to us and see that we let the blood pressure over a longer period of time of the map being that low. So try to have it in the at least upper 60s in the 70s. So autoregulation. What else? Increase in tubular flow reduces the GFR, and decrease in flow increases the GFR. The increase and possible increase in the afferent arterial pressure is stimulating renin release and is forming angiotensin II. You have a generalized vasoconstriction and decrease in the blood flow. And then you have at the other side, you have a relative preservation of the GFR mediated by prostaglandin synthesis D2, E2, and I2. And the sympathetic outflow is controlled from branches from T4 to L1. So that's another argument for placing the epidurals at least at mid-thoracic level. So what are the effects of anesthesia to the kidney? We have, in most of the cases, reversible changes in blood flow, filtration rate, urinary flow, and sodium excretion. Of course, the changes are less marked when you have regional anesthesia. Most of them are mediated by autonomic and hormonal influences, and most of them can be partially overcome by maintaining an adequate MAP. And only sevoflurane has a theoretical potential of renal damage with the formation of compound A. We have some indirect effects affecting the kidney function during anesthesia. Low MAP. Then we have some neural effects, sympathetic overactivation due to light anesthesia, surgical stimulation, tissue trauma or anesthetic-induced circulatory depression. And we have some endocrine effects like stress response to tissue trauma, circulatory depression, hypoxia or acidosis. Increase in catecholamines, renin, angiotensin-2 and aldosterone, ADH and cortisol are common, and all of these may decrease also the renal blood flow. Some direct anesthetic effects, the volatile anesthetics, halothane, enflurane and isoflurane decrease the vascular resistance. Methoxyflurane, what is that? Have you ever worked with methoxyflurane? If you're going to be participating in missions, you're going to find it, especially in Africa. Africa, they have tons of methoxyflurane and halothane. And methoxyflurane is also very common in countries of Eastern Europe. So methoxyflurane can produce a polyuric renal failure if you're going to have in concentrations more than 1 mg for more than 2 hours. SIVO and compound A at low minimal flows. The FDA is prohibiting us to have in the United States at flow. We have to have a flow at least at 1 or 2 liters. In Europe, in Europe there is no regulation about the flow, so we were using it in minimal flow with closed loop systems with some newer Drieger machines. And we do not have any increased kidney failures. But here we have to respect what the FDA is telling us. About the intravenous agents, propofol may reduce the filtration rate and the renal blood flow because of the sympathectomy and the blood pressure drop. Opiates and barbiturates are minor effects. If they're going to be combined with nitrous oxide, then similar effects as the volatiles. My beloved ketamine has minimal effects on the renal function. Then there are some problems with all these dopaminergic and alpha-adrenergic blockade drugs like droperidol may prevent redistribution of the RBF. Metoclopramide, phenothiazines may impair the renal response to dopamine, but we're not using that much dopamine. So now the analgesic ketorolac, ibuprofen, prevent the renal production of the vasodilatory prostaglandins, and they might lead to a profound decrease of the renal blood flow and the GFR. And the AAC inhibitors can potentiate the detrimental effects with vasodilation and the sympathectomy at the same time with of our anesthetics. And that's why one of the reasons that patients should not be taking their AAC inhibitors in the morning of the surgery. Now we have some effects by the surgical stimulation. Like the pneumoperitoneum, it is producing compartment syndrome-like state with an increased pressure, intra-abdominal pressure. Then it leads to an oliguria, that it is proportional to the insufflation pressures. So one more reason to tell the surgeons during the Da Vinci or other cases that they should try to avoid high pressures. Here are the effects on the kidney. So we have a very good communication with The surgeons in the urology department, I don't know how the communication with other surgeons in other departments is. Yeah, try to tell this to Dr. Morton. Good luck. And then we have there are some other surgical procedures too, like CABG and cross-climbing of the aorta and the dissection close to the renal arteries. And that's it. Simple. Questions?